Yeah, Rukiya, please give the countdown to Prashant.
Yes, sir. So we are live.
Shall we go?
Yes, sir. Yes, sir. We can start.
Kavan, can you switch on this introduction slide?
Will you able to see the screen sharing?
Sir?
Yes,
sir.
yes, Kavan. Yes,
Yeah.
Kavan.
Go ahead.
Kavan, we are not able to see your slide.
Yeah. So now, is it visible, sir?
No, no.
No, sir. No. It stopped, sir.
Now you are sharing, yes.
Hope it is visible.
Yes, yes.
Yeah.
Prashant, please start, and Kavan, please go to the next slide.
Next slide. Yeah. Good evening to all. I am Prashant Khokle, based out of Nagpur headquarters from Pfizer Oncology. And let me take this opportunity to introduce our distinguished faculties for today's session. I would like to welcome Dr. Sandeep Shah sir. Sandeep Shah sir is a part-time associate professor since 1996 and head of the bone marrow transplant at GCRI. Sir is one of the founder of HOC Vedanta Ahmedabad. Sir is practicing since 1990 as a hematologist and medical oncologist in Ahmedabad. Dr. Sandeep Shah sir has published 26 publications in national and international journals, written book on epidemiology of CML, and written chapters in 6 different books. Dr. Shah sir has participated in 28 clinical studies and given lectures and presentations in 15 national and international conferences. I would like to invite Dr. Sandeep Shah sir for this meeting and welcome Dr. Sandeep Shah sir. Our second distinguished faculties is Dr. Nishad Dhakkate. Dr. Nishad Dhakkate sir is a consultant and HOD of hemato-oncologist at HCG NCHRI Cancer Institute, Nagpur. Dr. Nishad sir is fellow leukemia and bone marrow transplant specialist and hematologist at BC Cancer Agency's Vancouver General Hospital, Canada. Also worked as a consultant hematologist and bone marrow transplant specialist at BGS Global Hospital, Bangalore in 2016. Dr. Nishad is a member of EHA, that is Mumbai Hematology Group, Delhi Hematology Group, and IMA, and also participated in various clinical trials, post-research work, poster presentations, and newsletters. I welcome Dr. Nishad sir for this meeting. And our third distinguished guest is Dr. Srinath Shirsagar sir. Srinath Shirsagar sir is a consultant hematologist and bone marrow transplant physician at Global Hospital, Mumbai. Since July 2018 till now. Sir is honorary consultant hematology at KJ Somaiya Medical College and Research Center, June 2019 till now. Sir has fellowship clinical hematology and stem cell transplant from Tata Medical Center, Kolkata. I also participated in more than 10 plus clinical trials. Dr. Srinath Shirsagar sir has participated in various paper presentations, poster presentations, and research work. I welcome Dr. Srinath sir for this interactive meeting. So thank you, sir. And Kavan, I would like to invite Dr. Sandeep Shah sir to take the session ahead.
Yeah, good evening, everybody, and thank you, Pfizer, for arranging this meet on Inosutumab, uh, changing paradigm in the treatment of adult acute lymphoblastic leukemia with recurrence or relapse. So we will be have a panel discussion for next 40 to 45 minutes. And Kavan, can you share the first slide?
Yes, sir.
So we all know acute lymphoblastic leukemia is in adults, it is a different disease, and in pediatric, it has a cure rate of almost 80 to 90%, while in adult acute lymphoblastic leukemia is not carrying that good prognosis, and majority of the patients will have relapse sooner or later. Around good risk patients, it will have a long-term survival without relapse, without allogenic bone marrow transplant in 25 to 30% of patients only. So when adult ALL, whenever they have a relapse, it is very difficult to treat, and particularly when they relapse on treatment, the prognosis is very bad, and the only curative therapy for us is bone marrow transplantation. So most of the patients after relapse, if transplant is not done, they cannot be cured. And as we all know that important thing is to achieve the second remission. Whenever these patients relapse, it is very important to have second remission, and if possible to get MRD negativity, and then when we proceed for transplant, we'll have some good overall survivor, or some patients can be cured. Next slide. So, Nishant, how many patients do you see for adult ALL in a year? And how many of them are relapsed or refractory adult ALL in your setting?
Sir, good evening, sir. So I see about 20 to 25 patients of adult ALL in a year, approximately 1 to 2 cases a month. And usually, they're diagnosed at our center itself, and some are diagnosed with a suspicion of acute leukemia. They come to us. They've already, they have already worked up outside, and with a suspicion of ALL, they come to us. So, what is the proportion of relapsed refractory adult ALL in our setting? The approximately 30 to 60% cases ultimately relapse, and most of the relapse occur within 1 to 2 years.
So, Dr. Srikanth, do you have?
So at my
any-
center, generally, thank you, sir. And at my center, we generally see 10 to 12 or maybe 15 patients per year. And most of them are B cell ALL. And approximately in adult, 35 to 45% patient will face a relapse in their due course of treatment. And that generally with us.
So the incidence of ALL will be different because you both are working in a corporate sector. I have an opportunity to work in a private clinic as well as in a government institute. So we see a lot of patients, but I think the number of patients who are getting treatment will be almost equal. So most of the patients, they don't take the complete treatment. In private clinic also, many of the patients, they go to government hospital once leukemia is diagnosed. And as you become senior, you get more of a relapse and refractory patients, particularly for transplant or second line therapy or for opinion. So that figure will change from institute to institute and from person to person, which we cannot generalize. So next slide, Kavan. So here you can see the ALL among adults diagnosed with acute leukemia and reporting institution. Was the paper of around from the 16 institutes. The same thing is shown here, that in different institute the incidence is different, the number of patients presented with relapse also are different, because the some of them are corporate hospitals and some of the institutes are trust hospitals and some are government institutes. So the incidence will differ from institute to institute. Next. We know that younger the patient of ALL, the cure rate is high. So in pediatric ALL, the cure rate is very high, but in adult ALL, it is not that high, except patients who are less than 1 years of age, where the prognosis is not that good. Otherwise, as the age increases, the prognosis and the cure rate is going down, which you can see here. Next slide. So once you get a new patient, what are the diagnostic tests which you do in all the patients? And the second question is CD20 part of flow cytometry panel in your institution, or where you are outsourcing it, or your associated laboratory?
So can I?
Yeah, Dr. Srinath.
Yeah. So generally for a diagnostic test, we use the first of all a peripheral smear. That's the most important test we do. And after that, once we establish there is a leukemia, then bone marrow flow cytometry, and as well as a fish for certain, especially 922 we do it. And after that, CSF analysis we do. Yeah, and in our institute, we do have CD22 as a part of flow cytometry for acute leukemias.
Dr. Nusant, do you have any different?
Yeah, so nowadays, sir, I have moved on to doing NGS in all my acute leukemia patients. So I have, apart from the routine basic workup, which includes peripheral smear, bone marrow aspirate, flow cytometry, karyotyping, and then I do a NGS. I have stopped doing fish as of now. We directly go for NGS. Both DNA and RNA is preferable, but if there are cost constraints, I only do the RNA NGS, which detects only the chromosomal translocations which are present. So it takes about 10 to 15 days for the results, but you get to see a lot of other mutations like Icaros, any mutations in the pH like problems like Icaros gene mutations, EGF1 mutations. So all these mutations can also be picked up by NGS. So nowadays I'm moving from the routine FISH and PCR test to NGS based platform.
Any you doing ploidy study?
Yeah, so ploidy study we do. When we send ploidy, we send it with the karyotyping. We don't get ploidy with NGS.
No, flow cytometry.
No, I don't do ploidy routinely.
Come on, next slide. So at our institute, also we do this routine test, immunophenotyping, but we don't send NGS panel for every patient. Usually we send ALL panel by FISH and routine cytogenetics. But sometimes we have to do bone marrow aspiration as well as trifine biopsy, because sometimes there are no blast in peripheral blood and aspiration is not possible if marrow is packed. You don't get any aspiration. So you have to send immunohistochemistry on trifine biopsy to confirm whether it is B cell or T cell. So that is trifine. When you don't get aspiration particularly, then trifine biopsy is very important to get immunohistochemistry and to see B cell or T cell. And then on those blocks, you can do the FISH. So patients where you don't get aspiration, I think trifine biopsy is very important. As usually, once this inozumab is available, we also now do always we ask for CD22, and rest of the thing I think lumbar puncture is done on the day 1, and CSF cytology is done. So that is how we do investigations in all the patients. Next slide. So Dr. Nishant, how many percent of patients relapse within the first year of diagnosis of B-cell ALL?
Sir, about say 40% of my patients will relapse within the first year of diagnosis of a B-cell ALL. The proportion is more when you see the T-cell ALLs, but B-cell ALL about 40% will relapse, and the majority of the relapses are present in the first year of diagnosis. 1 to 2 year is the most common time frame where the patients relapse.
And which protocol usually you use for adult B-cell ALL?
Sir, I am still using BFM protocol till the age of 40 years. After the age of 40 years, I am using most of the times I am using the GMAL protocol after the age of 40 years.
Okay. And Dr. Srinath, which
Yeah, so-
protocol you use for adult ALL most of the time?
I'm using BFM 95. But if the patient is young and having a pH positivity, then I may go to hypercivil for those patients with the dasatinib.
Okay. And how many patients you see relapse?
So approximately 35 to 40% patient will relapse, and most of the patients will be having a relapse in the first year of diagnosis, especially while they're on the maintenance, and that's what will be seen. And most commonest site of relapse will be the marrow, followed by CSF.
So I also use BFM protocol by and large, but as such, whatever name you give, the drugs are same, only there are marginal differences in the timings and doses. So those patients who are coming from far distance and cannot stay locally, in some patients still use MCP 841 because their patient is to be called only once in a week. It is a very simple protocol, and in our experience, we get almost the same results like BFM or other complicated protocols, because MCP 841, it is patient has to come just once a week, and patient can take L-asparginase intramuscularly at its local place. So in some of the patients who are not ready to stay locally, we still use that protocol, and I think almost similar results are achieved. And Dr. Srinath, what is the most common site for relapse in your practice?
Both of you, sir. Can I?
Yeah, yes, sure.
You change your practice from regular asparginase to PEG asparginase, or still continuing with the regular L-asparginase?
I think for us, it will depend on the patient's financial. Most of the time, we still use the conventional, particularly adult. As far as pediatric patients are concerned, we use PEG asparginase in almost all the patients. But adult patients, even sometimes if patient gets some complication, we omit L-asparginase also, because to use L-asparginase in pediatric patient and in adult patient is altogether a different game.
Yeah, I would like to comment, sir, here. What my experience is, we used to earlier see toxicity mainly because of the conventional asparginase in adults. So since the time we are using PEG asparginase, I don't see much toxicity of PEG asparginase in adult patients. So I use only PEG asparginase in adult patients because the conventional one has a lot of toxicity, and that is why the adult protocols, they initially there was a caution of increased asparginase toxicity, especially in adults. And since they are on lot of steroids, the complication of pancreatitis was one of the most feared complication. But with the use of PEG asparginase, the toxicity has reduced.
I think in our experience, we see a lot of altered liver function. Sometimes the SGPT and SGOT remains high for 4 to 6 weeks, and then we are afraid of moving forward with the further chemotherapy. So I think different people have different experience, but my personal experience, PEG
I
in adults is causing a lot of alterations in liver function.
I agree with your point, sir. Yeah, that's a very valid point. We see a lot of hepatic derangements, even with Peg aspergillus, patients do experience it. But still, I think we continue the Peg aspergillus part if the patient is all right.
Okay. So what is the most common site for relapse in your practice? Both of you
Sir,
can answer one
yeah,
by
sir,
one.
in my practice, I think bone marrow is the most common site of relapse, followed by isolated CNS involvement, and followed by combined bone marrow and CNS. Mm, After which, we can consider like isolated testicular relapse or cutaneous relapses, which are very, very rare, but those can be thought about.
I think I agree with you. Next slide. So we all know that if these adult ALL patients, they relapse, and we all know that they relapse within first or second year when they are on maintenance therapy. And you can see that in MRC UK LL2 trial and LA-LA94 study, the prognosis is very poor. 5-year-old survival is only 7%, and 2-year-old survival is 11%. So in both the trials, the prognosis is poor when patient relapse during first or second year when they are on treatment. Next slide. So the next important thing is when they relapse, how to treat them. So as I mentioned earlier, it is very important to get second remission before patient can be submitted for HSCT. And survival is dependent on the response to this second line therapy, either it is chemotherapy or immunotherapy. So those patients who achieve CR or MRD negativity, they will have a better prognosis, and those who don't achieve CR, the prognosis is worse and survival is almost zero in those patients. Next slide. So NCCN mentions these are the options for patients who relapse. Chemotherapy, second line salvage chemotherapy, or immunotherapy in form of either blinatumomab or inozumab. And the third option, which is still now I think it is not for Indian patient, is CAR T cell therapy. And those patients who are pH positive, for them you have to change the TKI, or as per the mutation study, you have to change the TKI and give second line of chemotherapy. Or now there are enough data to say that in these patients also you can add blinatumomab or inozumab. Next slide. And then it should be followed by HSCT once you achieve remission. So the only curative option is to do allogenic transplantation, either match sibling or alternate donor transplant once patient achieves hematological remission or MRD negativity. Next slide. So once patient is having relapse, Dr. Srinath, what is your goal? First initial goal.
So initial goal for getting him in some kind of a remission, followed by achieving him getting MRD negative status, and followed by doing a bone marrow transplant is my goal for this patient, for any relapsed adult ALL patients.
And do you repeat flow cytometry and genetic study again whenever patient relapse?
Yes, whenever there is a relapse, we repeat the bone marrow, we repeat the flow cytometry, and with that we also repeat karyotype. And in my practice, I do NGS at the first relapse, or if the patient is not able to achieve MRD negative status after the induction. That's the situation where I do NGS in ALL patients.
Yeah, Dr. Nissan, any other thought?
No, sir, ideally, yes, the goal of treatment in a relapsed case of ALL is to achieve a CR, the first and most important goal. It is always recommended to achieve MRD negativity, because then you will be consolidating it with a bone marrow transplant. And the data shows that if the patient has achieved MRD negative status, then the outcomes of a bone marrow transplant are superior as compared to when the MRD is positive. So achieving MRD negative is the second most important goal. This should, always be followed by a definitive treatment and a curative treatment, which is obviously in our setting is a bone marrow transplant.
So how many cycles you give? If patient is achieving MRD negativity after first cycle, do you repeat the same cycle or you immediately take patient for transplant?
So if the MRD is negative, I usually plan much ahead, and I usually try to take the patient for transplant as soon as possible after the first cycle itself.
So most of the time, I think there is no need of giving second cycle. On the contrary, we may add toxicities or some residual infection, and that will actually worsen the outcome of transplant also. So we also give one cycle, and if patient achieves MRD negativity, then we, as far as possible, we take patients immediately for transplant. So next slide. So what are your options in chemotherapy or immunotherapy according to the high disease burden status? Means what is your choice of therapy? Dr. Nissan first, and
Sir, usually, the most commonly used regime is the most commonly used treatment modality in my patients is chemotherapy. It's chemotherapy only. None of my patients have gone for agents like blinatumomab, CAR T cell therapy, or even inotuzumab as of now. In pediatric patients, I use the relapsed UKLL protocol, and in adult patients, I usually use hyper CVAD as a part of salvage chemotherapy.
Dr. Sinath?
In my practice, generally, chemotherapy still remains the mainstay of the patients with for a relapsed ALL. But I definitely give them option of going with inotuzumab or a blinatumomab. I have used inotuzumab in 2 patients and blinatumomab in 1 patient so far. Blinatumomab, I generally use it when there is a MRD negative, just MRD positive, and they are not achieving the MRD negative status. And inotuzumab, when there high disease burden is there, I definitely plan to put those patients on inotuzumab. Blinatumomab problem is that continuous 28 days infusion is little troublesome for the patient, while inotuzumab giving it easier, and most of it is an outpatient basis. So that's what my algorithm for the treatment for relapsed ALS.
Yeah, in India still I think blinatumomab is not available.
It's not available, yeah, but
yeah.
so not compassionate, but we can import it.
Yeah. So in our setup also, if finance and sources are unlimited or that finance is not the problem, I prefer inotuzumab because the patient's general health before transplant is absolutely means will not deteriorate just like chemotherapy, where you have to give some rest period, while inotuzumab usually does not cause any major side effect, except we all know that SOS or veno-occlusive disease. But otherwise, it is a very safe drug to use, and side effects like chemotherapy are not there. Those patients who cannot afford inotuzumab, then we have to use standard chemotherapy. And in our practice, we use particularly for isolated CNS relapse, we use phase B of hyper-CVAD, 1 or 2 cycle, and then we take patient for transplant. Otherwise, patient to patient, but usually high dose cytarabine is used most of the time for achieving second remission. Maybe cytarabine plus cladribine or cytarabine plus idarubicin. And then once MRD negativity or remission is achieved, then we take patient for transplant. So inosituzumab, particularly patients who are more than 40 years of age, or there it is very easy to administer, and there is no prolonged neutropenia, just like uh, when you use this high dose chemotherapy or like hypercived or high dose cytarabine. So in that way, inosituzumab is very easy to use, and we'll see in the next slide that it causes a very high incidence of complete remission as well as MRD negativity. Next slide. Next. So this is a very known trial, and we all know that inosituzumab achieved higher rates of CR and CRI and MRD negativity among responders versus standard chemotherapy. And almost 80 to 90% of patients achieve MRD negativity in those patients who achieve CR or CRI. While with standard chemotherapy, usually the response rate is not that high, and even you can see CR and CRI are only 40%, and MRD negative it is even less. So if finance is not the constraint, then definitely inosituzumab is, for our setup, it should be the first choice. Next slide. So we already discussed that it is inosituzumab is associated with high MRD negativity rates, and we all know that the outcome of transplant will be much better in those patients who achieve MRD negativity. Next slide. So the MRD negativity also goes on increasing with the first cycle. The MRD negativity is around 50 to 45 to 50%. With next cycle, the MRD negativity is almost 87%. So as you use more cycles of inosituzumab, the MRD negativity rate also increases, and 87% patient achieving MRD negative CR CRI with inosituzumab, which was achieved in two or mostly in 2 cycles. Next slide. So MRD negativity is associated with overall survival benefit in patients treated with inosituzumab, and even in patients treated with chemotherapy. So those who achieve MRD negativity, the overall survival is much better. Progression-free survival is also much better, and the relapse rate is very low post-transplant. Next slide. But in, I think, our most of the time I have used only one cycle because of the constraints of the fund, and almost 80% patients I have used in around 12 patients this inosituzumab. And last patient was the first incidence where after giving inosituzumab also, after end of the first cycle, there were 60% blast in peripheral blood itself. So I did not go for second cycle, and then that patient was given chemotherapy. But otherwise, most of the time after first cycle, CR is achieved, and most of the time MRD negativity is achieved. Next slide. So same thing is shown here again, that achieving MRD negativity and receiving HSCT was associated with improved survival. So to achieve MRD negativity is very important, and if patient can afford, usually at least 2 cycles of inosituzumab should be used. That is day 1, 8, 15, 28-day cycle, and that cycle should be repeated. And in almost 80% of patients, you can get MRD negativity. Next slide. So as I told you that except for VOD, the other side effects are very minimum, and they are easily manageable compared to the chemotherapy. There is no prolonged neutropenia, no febrile neutropenia, and most of the patients, they tolerate inozumab very well, and usually BOD is not common when you are giving this cycle one, so first cycle or second cycle. VOD usually occurs post-transplant, and the incidence of VOD usually is more after transplant. The incidence during therapy of inozumab is hardly 3 to 5%. Next slide. So we have already seen here that to give the best salvage therapy according to the patient financial status and disease burden status, and then patient should be submitted for HSCT for the intention of cure. Next slide. So we have, I think, still finally, I think, final comment on the salvage therapy from both of you, Dr. Srinath.
So in my opinion, still I'll keep inotuzumab as a first option, given the choice that there are no financial constraints for a patient with relapsed refractory, followed by the chemotherapy. And we still don't have inotuzumab and CAR-T cells available in current situation. So inotuzumab will be my first option for the patients.
Dr. Nishan.
Yeah, undoubtedly, I think, whenever I come across a patient of relapsed refractory B-cell ALL, I usually counsel them for inotuzumab, which is a very much easier regimen to administer. It can be given on an OPD basis as compared to, chemotherapy, which would be very toxic and requires inpatient admission. Again, blinatumab requires 24-hour infusion, and that is why inotuzumab has a superior edge over the other two regimes which are most commonly used. Also, inotuzumab, it has a very good response rate when it comes to the amount of blast percentage and other things. So inotuzumab is undoubtedly the preferred regimen in relapsed refractory B-cell ALL.
So you brought out a very important point, which I forgot, that this can be given on OPD basis. In most of our patients, we have given it on OPD basis only, just short infusion, and after 1 hour patient can go home and again will come on day 8 and day 15. So that is very important that patient can be given this therapy on OPD basis only. And Dr. Sina, do you use any chemotherapy before giving or along with inozumab, any chemotherapy?
No, sir, I use single-agent inotuzumab. And if the patient is Ph positive, then dasatinib any TKI, that will be the choice. And generally, I have faced severe neutropenias with usage of inotuzumab. One of the patient I have lost because of neutropenic sepsis post inotuzumab therapy. So I generally very skeptical of using any chemotherapy drugs with inotuzumab.
You had a severe neutropenic sepsis with single agent inotuzumab.
Single agent inotuzumab.
I'm surprised. I have never seen severe neutropenia post inotuzumab. There is mild neutropenia may occur, but I have not seen single patient with severe neutropenia with inozumab.
The patient had received lots of chemotherapy previously, and he was not achieving MRD despite of 2 salvage regimens. So eventually we had to go ahead and plan for inotuzumab. That was the situation. He was 2 times relapsed.
I think one of the reason can be the marrow must be full packed with the blast cells, and maybe the disease must be very sensitive to inozumab, and I think it could have taken long time to marrow to recover because of that, I think.
So far, giving it not a problem, but not with the chemotherapy, I haven't used it in any of the patients.
Next slide.
Would you, sir? Hello.
So, hello.
Yeah, so what about you? Have you used inotuzumab with chemotherapy?
No, in some patients when the WBC count is very high, or then I give one cycle chemotherapy and I brought down the WBC count down, and then after 1 week I start with inotuzumab. Instead of starting with, if the WBC count is very high, more than 50,000 or 1 lakh, then I give one dose of chemotherapy to just bring down the WBC count, or some tumor burden is reduced, and then I start with inotuzumab. And sometimes you also want to buy till patient arranges for the fund, and sometimes they take long time to decide whether to go for it or not. So chemotherapy dose is already given, and then they say that now we are ready. So those are the situations where chemotherapy is given before inotuzumab. And again, here it is shown that when you use as your first salvage inotuzumab, the results are much better than when you use as a second salvage. So this is clearly showing that the MRD negativity is higher when you use it as a first salvage other than as a second salvage therapy. Next slide. And similarly, if you use, so any therapy, when you use it early, the results are going to be better. And here it is shown that when you use it as a first line therapy, even the overall survival is also much better. Next slide. And because you achieve more MRD negativity and more CR with first line salvage therapy with inotuzumab, more number of patients will go for transplant compared to the standard of care chemotherapy. Next slide. So here again, it is compared the safety profile of inotuzumab with standard of care chemotherapy. You can see that the complications are, most of other complications are less with inotuzumab with one cycle, and even with second cycle also the most of other complications are less with inotuzumab, except VOD incidence is high with inotuzumab, and particularly it is more high when it is used as a second salvage therapy. Next slide. So we have, I think, already discussed that choice of treatment when there is a high burden disease and blast count is more than 50%. I think this is the drug which should be used as a first salvage therapy, and the results are best when it is used as a first salvage therapy. Next slide. So even if bone marrow blast counts are very high, then also the results with inotuzumab are better than standard of care chemotherapy, which is shown in here in this slide. Next slide. So we already discussed it, that even if the number of bloods are very high in peripheral blood or bone marrow, in spite of that, with inotuzumab, more number of patients achieve CR, and more number of patients will proceed for the transplantation compared to the standard chemotherapy. Next slide. Again, same thing, that it improves survival irrespective of the bone marrow blast count. So by all means, inotuzumab is better than standard care or second salvage chemotherapy, except financial toxicity is more with inotuzumab. Otherwise, by all means, it is better than chemotherapy. Next slide. So for extramedullary disease also, outcomes appeared improved with inotuzumab compared to standard of care chemotherapy. And in that trial, the sample size was small, but again, you can see the CR rate is almost 70% with inotuzumab compared to around 20% with standard of care chemotherapy. So even for extramedullary disease also, inotuzumab is superior to chemotherapy. Next slide. So safety profile, whether the blast count is high or low, the safety profile remains the same, and the side effects don't increase with the increased number of blasts in the marrow. Next slide. Next slide. So same thing is shown here, that with low blast count or moderate blast count or high blast count more than 90%, the still inotuzumab remains the better compared to chemotherapy in the form of side effects and other non-hematological side effects. Next slide. So I think the question to Dr. Sinat, what is the long-term overall survival in your treatment setting in patients where you transplant after achieving second CR, or some patients because of various reasons you may not proceed for the transplant. So what is the long-term overall survival in those both group of patients? Dr. Sinath?
So my answer to this question will be, first of all, I'm very short term in my practice, so I cannot comment about a long term overall survival in my practice. But generally, a patient who had undergone transplant for relapsed ALL, out of 80% are still in remission, and they are doing good so far. And the numbers are very less.
Some of the patients must be
and the
not
patients who
ready
haven't
for
gone for a
transplant.
transplant, so out of which, though one of the patient is currently on a treatment and is on a metronomic therapy right now, and rest of I have lost all the patients. Out of 10, at least 8 patients I have lost for with the patients who haven't gone for a transplant in the ALL patients.
Dr. Nissan?
Sir, so overall, long-term overall survival in my adult ALL patients is about 40 to 50%. If you talk about relapse patients have a very dismal outcome in my setting. Once they relapse, the outcome is only about 10 to 20%. Most of my patients haven't opted for the transplant. Have not opted for inotuzumab or blinatumomab, and hence once an adult patient relapse, the outcome is very, very dismal.
So how much gap you will keep patients if patient is treated with inotuzumab? Then after what interval you will take patient for transplant? If patient has achieved MRD negativity, say after first cycle, so whether you will give second cycle, or how much gap interval you will keep before taking patient for transplant? I think Dr. Sinath has used inotuzumab, so he can answer.
Yeah, so generally, if patient has achieved a MRD negative after first cycle, I won't give the second cycle. And from inotuzumab cycle to a transplant, I will generally keep at least 15 to 20 days gap between the last dose of inotuzumab and going for a transplant.
So I think usually around 6 weeks of gap should be kept from the last dose of the inotuzumab. 6 weeks I think are minimum to prevent the VOD, to reduce the incidence of VOD. And second thing is, I start using this UDLIV from the day we start with the inotuzumab till the transplant is finished. So that also is the incidence of VOD. As far as possible, hepatotoxic drugs or azoles are avoided by using transplant, and double alkylating agent also should be avoided if possible. So usually in ALL, I think we all must be using TBI as
keep defibrotide as a backup when we use inotuzumab for transplant patients with ALL.
Usually we give TBI liver sparing so that damage to liver is prevented. Next slide. So here you can see the long-term survival is 2-year survival probability higher with inotuzumab, which is here it is shown around 30% only after relapse, compared to chemotherapy it is around 10%. Next slide. So similar thing is shown here, around 30 to 40% patients ultimately survive more than 2 years when the transplant is done after achieving MRD negativity. Next slide. So what are the most common adverse events in your experience with inotuzumab, and what is the VOD incidence, and what are the strategies to minimize it? So you can summarize, Dr. Srinath.
So most common adverse event in my experience is the neutropenia, followed by VOD in the patient who had undergone transplant. I've lost, means the patient was not mine, but taken the inotuzumab and gone for a transplant at some other center. And we lost him because of VOD during the transplant. And generally, at my place, we generally use UD leave, like Sir had said, from day we begin inotuzumab and we continue till the post-transplant period. And generally, we do not use double alkylators. TBI with a liver sparing TBI is also commonly used nowadays. And we keep defibrotide as a backup in the patient who was already taken inotuzumab and was planned for a transplant. Though we haven't used it ever so far, but we just keep it in pharmacy for the transplant patients.
Next slide. So the median. Next slide. So as I mentioned before, the incidence of VOD is higher post-transplant rather than during the therapy. So median time to VOD after HSCT with inotuzumab was 15 days versus 3, 14, and 38 days for the 3 chemotherapy patients. So usually post-transplant after 2 weeks, chances of VOD are high, and post-transplant around 20 to 25% patient will have VOD, while during therapy hardly 3 to 4% patients have VOD. Next slide. And I think we have to keep the gap of around 6 weeks after the last dose of chemotherapy. Next slide. So the risk factor for getting more VOD are using dual alkylator conditioning, and the incidence reduces if you use single alkylator. And if patient is having a higher bilirubin or altered liver functions before transplant, then also the chances of VOD are high. So if we pre-HSCT, AST or ALT level are high, then also the risk is increased. And previous history of liver disease, or patient if having HCV or HBsAg positive, definitely the incidence of VOD will increase with the use of inotuzumab. Next slide. And if you use more cycles, the incidence of VOD will increase. You can see with one cycle it is 8.3%, with second cycle it increases to around 20%, third cycle around 25%. And if you use more than that, the incidence is almost more than 40%. But most of the clinicians, they don't use more than 2 cycles. And if MRD is achieved after first cycle, I think there is no need for second cycle. Next slide. So these are the maneuvers by you can reduce the incidence of BOD. We already discussed avoid the dual alkylating agents, use prophylactic agents, urocidol, and when possible, avoid hepatotoxic agents, particularly azoles. You should use fungal prophylaxis either with caspofungin or mycofungin. And in patients proceeding to HSCT, limit treatment with inozitumab to 2 cycles. Next slide. So this is a general question. So in your opinion, I think Dr. Nishant, you already mentioned that it can be given on OPD basis. So what do you think the burden of hospitalization or the overall cost will be less with the inozitumab or it will be with chemotherapy?
I think, sir, definitely the cost would be much, much lesser if you use anituzumab as uh, upfront, because if you use chemotherapy, the cost of burden of hospitalization will be more. The patient needs to be indoor for almost 4 weeks before any count recovery could happen.
So I think particularly if we have to admit patient in corporate hospitals where the hospitalization burden is also very expensive, and the other drugs, management of febrile neutropenia, antifungal drugs, all those, if you consider, overall inozitumab will be cheaper or it will be as costly as uh, second line chemotherapy. But in government hospitals where hospitalization is not charged and the drugs, antibiotics and all other drugs are very cheap, there I think chemotherapy option is cheaper than inozitumab. So I think other than government hospitals where the hospitalization itself is not charged, I think most of the other setup, I think inozitumab overall, if you consider, it will be cheaper and more safe. Next slide. So here it is compared, and I think we all agree that hospitalization burden will be less with inozitumab. Next slide. Next slide. So as the number of cycles of chemotherapy will increase, the hospitalization burden and other cost will also increase. Next slide. Next slide. So this was the paper presented in EHA 2021 and AS 2021, and it has shown that outcome of relapse or refractory acute B lymphoblastic leukemia patient with extramedullary disease receiving inotuzumab ozekimicin is even it gets very good response, and even it is better than chemotherapy. Next slide. So patient characteristics are given and compared, and most of the time the extramedullary relapse is in lymph nodes or in testes or other soft tissues or sometime osteolytic lesion. Next slide. But as a whole, inotuzumab still works in extramedullary disease, and the response rate is higher compared to the standard chemotherapy. Next slide. Next slide. And the safety is also same as we use it for bone marrow relapse. Next slide. So that is all for today, inozitumab. Thank you, both my panelists. And I think as we use in more number of patients, we will have more experience, and I think I have used it in around 12 patients, and most of the patients, except my last patient, most of the patient, I could take them for transplant. And by reducing by using single alkylating agent or TBI and fludarabine, VOD was complication only in 2 patients, and both patients I was able to salvage. Although there are other complications by which I lost few patients, but not by because of BOD in those patients where I have used inozanimab. So thank you very much, Dr. Nisad and Dr. Srinath. And I think I will ask Pfizer people to take it back.
So, first of all, thank you very much, sir. Sandeep Shah, sir, for taking us through swiftly in the relapse and refractory ALL cases, case studies, and all. And it was a very well interactive session. Ruqayya, I would request you, can you see any questions in the chat box for the panelists? If there are no questions, we are good to close. But before that, just wanted to brief you regarding the patient assistance program for inotuzumab. For patient who are transplant eligible, where patient assistance program is like, if patient requires 3 vials, then patient has to purchase 2 vials and 1 vial is given free to the patient from the Pfizer. And if patient require 4 vials, then up to 2 cycles, then patient has to purchase 3 and 1 vial will be given free to the patient. And transplant ineligible patients, from cycle 3, patient has to purchase only one vial, and then rest all the vials given free to the patients. So
my request is to give it for pediatric patients also, that EAP.
So still it is an off-label indication, but definitely, if at all, is there any labeled indications, we will definitely start to give in pediatric segment as well.
Because everybody is using in India and outside India also, everybody is using this drug for pediatric patients.
Yeah, yes. And there are quite a few patients in pediatric as compared to adult patients. So I would like to thank you, Sandeep Shah sir, Dr. Srinath sir, Dr. Nishad sir, for this wonderful session. And it was really great insights, given insight to the all the delegates and panelists. So on the behalf of Pfizer, I would like to thank all the panelists, and it was a nice time, sir. Thank you very much. Have a good time and good night.
Thank you very much.
Thank you, sir.
Thank
Good
you,
day.
Pfizer, and thank you, Sandeep Shah, sir.
Thank you, Dr. Nisad and Dr. Srinath.
Thank you.
Thank you, sir. Have a good day.
Thank you, sir. Bye, sir.